Welcome, everyone. My name is Nicholas Franco, and I'm a coordinator for the ACP Long COVID interest group. And it is my pleasure to introduce our leader and director, Dr. Anita Chopra.
Thank you so much, Nick. Thank you for making this possible. I am Anita Chopra. I am the chair for the Long COVID, ACP Long COVID interest group. I'm also a lead physician at the University of Washington Long COVID Clinic and a co-investigator for the University of Washington Long COVID AHRQ grant. It is such an honor for me to welcome my friend and colleague, and actually a teacher as well for me, Dr. Andrew Ayers. Dr. Ayers is clinical associate professor, volunteer in the Department of Medicine, Division of Allergy and Infectious Diseases at UW Medicine. He currently practices at the Bellingham Asthma, Allergy and Immunology Clinic, much to our sort of sadness that he has decided to move there. Dr. Ayers did his medical school at St. Louis School of Medicine, residency in internal medicine at the University of Colorado Health Science Center in Denver, and allergy immunology fellowship training at the University of Washington in Seattle. Welcome, Dr. Ayers.
Nita, thank you so much for inviting me. This is great.
Thank you so much. And today we will be talking about the immunological processes in long COVID and the immunological considerations in long COVID. So I would encourage you guys to ask questions. I think that this is by far the most challenging specialty in terms of the long COVID care. So, Dr. Ayers, what are the immunological processes actually of long COVID? Can you talk about the immunological pathways involved in long COVID?
Yeah, as we all know, that's very tricky, and there's a lot of different theories, a lot of great theories that may hold water, but not one immunologic theory is dominant as to what drives this condition. But I figured we'd be talking about this, and there was a great review article in JACI in Practice, which is our major clinical journal in our field, which had a nice kind of review of the proposed immunologic mechanisms and some that there's evidence for. So if it works for everyone, I was just going to bring up a few slides. I don't have a ton. I won't bore you with a talk here, but if it works, I'm going to bring up a few slides. So share screen. Let's see. Sorry about this. Can you see my screen now? Okay. So I actually really like this slide because it goes over all the potential mechanisms, and there are a bunch out there, and I've tried to stay abreast of most of them, but it's kind of hard to keep up. But I really like this slide because it goes over kind of the major mechanisms we think of in immunology, not just for COVID, but for other infections. And in our field, a majority of what we see is allergy, but as allergy and immunologists, a lot of us, including myself, about 20 to 30% of what we see is immune deficiency, or basically people born without immune deficiencies at birth or common variable immunodeficiency. So, a lot of what we do is immune workups. And when these patients first came in, I was convinced they had to have an underlying immune deficiency. This is more of a chronic infection. So as far as the proposed mechanisms, one of them I've seen thrown around is that we're just not able to clear the virus completely. Basically, we get rid of the major infection, so you don't get the major shedding, you don't pick up COVID positivity. But they have found in PBMCs some of these, some viral RNA up to a year after infection. So there's a thought that there may be kind of a low-grade infection that we're just not able to clear that could be driving some of these symptoms. Now, at least in my experience, I haven't seen that peripheral inflammatory markers are elevated or anything like that. But when I first started seeing these patients, I would do an immune workup, like how do you use your specialty to try and figure this out? So when I first started seeing these patients, I would do our classic immune workup to see if they're able to clear infections. And to cut to the chase, most of the immunity workups I've done on these patients have been stone cold normal. There is a theory that there's low-grade viral infection, and that kind of causes a chronic low-grade infection that we aren't able to pick up peripherally, but that people see the effects of. Another thing they've seen in these patients is that they get reactivation of herpes viruses, including EBV and HHV6. The classic model we see that in is DRESS, or drug rash with eosinophilia and systemic symptoms. Actually, that's one of the diagnostic criteria of DRESS, is that in the PCR, you'll pick up EBV and HHV6. Now, it's not thought to be part of the underlying disease process. And actually, even in DRESS, we usually don't use antivirals to treat it. It's just kind of a marker of other inflammation going on. And they have seen, EBV reactivation. It's not something I routinely check just because we don't usually treat it, but it is a marker of a possible low-grade infection. So, I've seen, trials or small trials looking at antivirals, and I haven't used these, but for the most part, I haven't seen a lot of success. So it's not been something I use, but that's one of the major theories I've seen thrown around. Another big theory you see is that, intestinal, the microbiota. And that's, something we think about. The gut is a very intelligent organism, and it has a lot to do with our immunity. It's not just genetics that go into our immunity. It's how we are interfaced with viruses, especially early in life. And in our field, allergies are a relatively new phenomenon. The first case reports of hay fever were from England in the late 1800s, so in these more industrialized places. So allergies are relatively new, but they've, shot up over the years, obviously. And, about 30% of the population now has one form of allergy, which is great job security for me. But no, it is an issue. And the reason we think that is it's the whole hygiene hypothesis you may have heard of. Not only are genetics based early in life, but our early life exposures really shape our immune system. And that goes on throughout life. It's most pronounced early in life. But we found that the people with the lowest incidence of allergies are those that are born on farms and exposed to the most amount of species of animals early. So the most you're exposed to early on. So it's good to have a diverse biota. And there's some theory that that's playing a role in this. And I've seen, some people try, over the counter, supplements to try and treat this. And the idea is great. But, we just haven't seen any evidence that, supplementing some of these bacteria in the gut have been beneficial. But that's, a great theory. And actually, I saw another study that showed that people who are pescatarian or vegetarian often have slightly better outcomes with COVID. So there's thought to be something in the diet there as well. But I personally don't recommend any diet specifically. The next is autoimmunity, and that's another thing we look at. Like I said, we see a lot of immune deficiency, and depending on the specific mutation, immune deficiencies not only are just increased susceptibility to infection, but it's immune dysregulation altogether. It's not just increased infections, but people with these underlying immune issues are predisposed to have more autoimmunity as well. So that's another thing I thought of, especially when this initially came out. Actually, something we see a lot of, and a lot of you may see this in clinic, is chronic hives or chronic urticaria, which is basically an autoimmune condition. But with that condition, we know that when there's an inflammation in the system, whether that's infection, trauma, things like that, you're more likely to have a flare. And we were seeing a ton of this, especially initially with not only COVID, but with COVID vaccinations, that about 2 to 4 weeks later, people would notice that their hives would return. They'd either had it before and been diagnosed it and flared, or it was a new phenomenon. So we know that both COVID and the COVID vaccines cause a lot of inflammation. And the COVID vaccines, that's what we want, obviously. But we saw a lot of this. Actually, we even published on it regarding how often we were seeing this autoimmune condition, chronic urticaria, after infection. But, other than rheumatologists who are much better than me, I'd look for a lot of, rheumatologic conditions just because they go along with immune deficiencies. And initially, I was doing a lot of autoimmune workups, and we're not picking up a lot, but that is something that we look at in general. And again, chronic urticaria is kind of that main example. I'm not going to get into this. I'm sure others in the group know a lot more about this than me, but clotting abnormalities, endothelial abnormalities are thought to play a role. But finally, we get into neurologic signaling. And I know you had Dr. Yang, Eugene, to come in and talk about this, specifically POTS, postural orthostatic tachycardia syndrome, which, a lot of these people have phenomenons. We'll talk about this later, but that POTS, Ehlers-Danlos syndrome, and mast cell disease are something we've seen in our clinics for years, and mast cell we'll get into in a little bit. But these patients have very similar symptoms to what we see with mast cell disease. And there's been reports, and I've seen this in my clinic, that some of these patients do have some response to the same therapies we use for mast cell disease. And those kind of run along with POTS and all that. So, I don't have great data regarding the mast cell component, but I do know that a lot of these patients have seemed to improve, similar to the mast cell patients that we've seen. So POTS, neurologic signaling, but that also goes along with mast cell disease. And they have found that in a lot of these patients with long COVID, that mast cell mediators are not just elevated in the initial component, they're elevated for up to a year a lot of the time. So especially in the acute phase, I have had some benefit using the typical medications we use for mast cell disease on some of these patients. So suffice to say, it may be a lot of these mechanisms, but there's not one dominant one that we've seen or that we're going after. In preparation for this, I did do some more reading recently. My wife did a talk at a conference in Minneapolis this past week, so I was reading on the plane, and I did find some other immunologic abnormalities that they've identified in some of these long COVID patients. In PBMCs, they have noted decreased CD4 cells in the absence of HIV, obviously, but they have noticed decreased B cells. And also they've noticed markers of exhaustion or programmed cell death are higher in some of these patients as well. Another big thing I saw recently that I hadn't seen before is they think that innate immunity is involved in some of this, and specifically mannose-binding lectin, which is part of the innate immune system that helps clear off a lot of the debris after infection. And specifically one called mannose-binding lectin, which is part of the complement cascade, which helps clear off debris after infection. They find that those levels are lower, meaning that it's possible that they can't clear these infections. And not only are active infection maybe playing a role, but also having a lot of these particles that occur after infection around can lead to increased autoimmunity and a lot of other things. So it's not that the innate immune system may be involved as well. And finally, neutrophils. They find a lot of these neutrophil extracellular traps, or nets, what we call netosis, which is kind of a net that they expulge that kind of traps bacteria, viruses, inflammatory mediators. So they found involvement of a lot of these cells, but it's not one specific pathway. So I admit it's been very difficult. And I kind of go through a lot of this with patients, and then they say, what do you want to do with it? And I say, gosh, I'm not sure. But no, we do know a lot of these immune mechanisms seem to be involved, but the dominant pathway, at least in our field, has not yet been elucidated. So.
I think this was the best explanation of that first slide that I have ever heard. So thank you so very much for walking us through the mechanisms. And, I have such a wonderful understanding of it. And thank you for giving us these examples. The next question that I'm going to ask you, actually, you did answer some of it already. I wanted to talk to you about the phenotypes. What are some of the clinical phenotypes that you see? You talked about urticaria, you talked about POTS. What are some other things that you are seeing in your clinic with long COVID patients?
Yeah, no, I admit there is a referral bias to me, just because mast cell disease, and we'll talk about that in a second, has a lot of overlap with the symptoms, specifically brain fog. Mast cell disease came to be in our field about 15 years ago. And for lack of a better term, there's a lot of different things that go into it. But mast cell activation syndrome, there are markers and all that. So we know it's, obviously a real phenomenon, but it's challenging to treat for a lot of different reasons, but brain fog and fatigue are two of the main symptoms that people present with this condition. So I've kind of been seeing these referrals for years, but now they're coming in, after post-COVID, complaining of a lot of these other things. And actually, I saw a patient today that had seen 3 different providers, and 2 of them have told him that post-COVID really isn't a real thing. And she was basically in tears in my office and just telling her, yes, this is a real phenomenon. And she also came there for hives. She was referred for hives, but she had kind of given up on the long COVID thing. And she just felt better knowing that this is something that we, obviously we see, it's a real phenomenon. So, basically what I see are the brain fog, fatigue, but if they have other symptoms, flushing, itching, things like that, that's a majority of what I see with these patients. Again, with me, I think it's a lot of referral bias. You get more of the generalized cases, but I tend to see a lot more of them, especially if they have itching, mast cell degranulation symptoms, hives, angioedema, things like that. But again, a lot of times I'll just get referred to them for kind of the more non-specific symptoms, malaise, fatigue, and brain fog is the big one. I get a lot of self-referrals because mast cell, it's a long story how I got involved, but when I was a fellow at UW, they made me do it, or not made me, I got to do a talk at the national meeting, which happened to be in Seattle. So I kind of fell into this mast cell field, and I kind of became the mast cell person at UW for 15 years. So if people go online and Google brain fog, oftentimes my name comes up, and that's not anything I've done. So they will come to me for brain fog a lot, and talking with them, obviously post-COVID is something they know a lot about. So I get a lot of referrals for brain fog and for if they have any component of urticaria, angioedema, but I am getting more and more just general long COVID, especially up here, just because I don't have the specialists or as many as we do down in Seattle. So I mainly see brain fog, severe fatigue with associated skin symptoms, but you see the whole gamut.
Thank you very much. And now I understand a very interesting thing that you pointed out, which is the relationship between urticaria, perhaps as a presenting symptom of mast cell activation, but also with brain fog. So I'm very curious to get your thoughts about the next question, which is mast cell activation, which is, I think, going to be the biggest, the meat of our talk. We see a lot of patients who come in who have had this diagnosis already.
Sure you do.
Is that something that they have? How is it, first of all, how is this condition diagnosed in long COVID patients? How do you make that?
That is a great question, Anita. Let me bring up a slide here, because it is actually, even in our field, a lot of people won't see mast cell. They just, it's a challenging group, and there's a lot of different types of mast cell disease. So let me bring this up. Can you see my slide there? Okay. So actually, I was just going to bring this up first. So for mast cell disease, again, it's something I've been seeing about 15 years. And the typical presentation, and this is kind of the spiel I go through with all the patients who get referred to me for mast cell. And actually, I was getting so many, I only see them on certain days at certain times. And they're great patients, but they have a lot going on for sure. But mast cells, as we all know, sit in the skin, GI tract, respiratory tracts. You sit by, the blood vessels. They're involved in neurosignaling, things like that. So they can cause just about any symptom depending on where they are. That's why this is on the differential diagnosis for a lot of different things. People sit on a computer and say brain fog, itching, and GI upset. And this is one of the first things that comes up, long COVID, things like that. So, people get online and they see flushing, itching, swelling, they can have a lot of nasal symptoms. People notice wheezing, bronchospasm, especially when they're having an acute episode. GI symptoms are a major issue, as they are with post-COVID in a lot of patients, but you typically see diarrhea, cramping, nausea, vomiting, and cardiovascular. I'm sure Eugene touched on this a bunch, but the hypotension, and they often describe very labile blood pressure and heart rate. So they'll come in and say, my heart rate's on my watch is 140, and 10 minutes later it's 70, and I'm just sitting down doing nothing. So a lot of them, especially with watches now, are coming in and saying, my heart rate's really labile. And then the big one is brain fog. Brain fog is something we hear a lot of in our clinics, and it is associated with mast cell disease, and we'll go over the different types in a second. But brain fog is one of the most bothersome symptom for patients. And we don't completely understand it in the mast cell setting. We think it's a lot because of histamine, leukotrienes, prostaglandins all being elevated, but we don't completely understand it in this setting. So again, this kind of goes back to the last question, why I see a lot of these patients and why I've been kind of seeing patients indirectly for post-COVID for years. Initially, I was getting a lot of referrals for immunodeficiency, but the majority of the referrals I get now are this in the setting of mast cell disease. So I take this diagram out for my patients as well when I'm seeing them, just showing them that mast cell disease is not one neat, clean diagnosis. There's several different ones. And the classic, most long-term one we've noticed is actually a clonal disorder. So for lack of a better term, it's kind of a low-grade malignancy, whereas the malignancy, people have a normal lifespan, but they just have too many of these cells and they're too twitchy. And we actually know exactly where that mutation is. It's called the D816V mutation. And people with mastocytosis have significantly elevated mast cells and bone marrow. So, it can be a very severe condition and it can progress to malignancy very rarely. But mastocytosis was kind of the first condition that was recognized in this class. And we do have very strict criteria. Most people need a bone marrow biopsy to have this drawn. Most people, the tryptase level is elevated. And that's the one test, if you're not drawn already, is one that I would recommend if you're doing screening labs, just to throw in a tryptase. And we'll get back to another reason why. But tryptase, usually they're significantly elevated in this setting. And usually you can tell these patients when they come into our clinic based on tryptase level. So I'll usually send them for a bone marrow, and those are kind of a separate category. Now we get into the secondary and idiopathic disorders. The secondary mast cell disorders, a lot of us on this call have it, and, seasonal allergies, and allergic asthma, things like that, food allergies. But that wouldn't cause all the myriad of symptoms. A food allergy wouldn't explain this. Seasonal allergies, that kind of thing. So we get down into the idiopathic conditions. And as you can see here, idiopathic MCAS, or mast cell activation syndrome, is one of the main things we see. And that's where most of the people refer to us. They kind of fall into this category. And in general, there are three criteria. One is symptoms of mast cell disease. And as you can see, that's really difficult because they can involve skin, GI tract, respiratory tract, that whole thing. The second is improvement on mast cell-directed therapies. And that's the one nice thing about this condition. Most of the mast cell-directed therapies we have are very safe. And people with the conditions like mastocytosis or mast cell activation syndrome that's been definitively diagnosed, they help a lot. And you can go way up on the doses. So I tell people that's the one nice thing about mast cell. If it's causing your symptoms, the therapies I'm going to put you on are relatively benign and can be very helpful for this. So the first criteria is symptoms of mast cell, which can be very difficult. They overlap with POTS, EDS, a lot of different things. The second, improvement on mast cell-directed therapies. And we'll go over a few in a second that I'll often start because, again, there's minimal risk with these things. And the third is the hardest one, and that's an elevated mast cell mediator. And most of them are beyond the scope of this talk. And if you're concerned about it, refer them to us. And most allergists will at least work this up. But tryptase is the biggest marker. And sometimes we'll do that not only at baseline, but when they're having symptoms. But if you take away one thing as far as the workup for mast cell, getting a baseline tryptase can help evaluate for the clonal disorders. And there's actually another condition we'll go over in a second called hereditary alpha tryptosemia that some of these patients may have as well. So again, MCAS is a very challenging group of diagnoses. And yes, it is overdiagnosed, in my opinion, and most allergy and immunology doc, it is overdiagnosed. People come in with hives, blood pressure changes, and they say, oh, you have mast cell disease, and they don't really work it up. That's how most people get these diagnoses. So, when people tell you that mast cell disease, it's certainly not always the case. But a lot of these people are kind of on the fence. So if they have symptoms consistent with mast cell, I'll often try these therapies and I'll tell them, look, I don't know if this is going to help, but the risk is relatively low. And I don't know how much of it's supratentorial, but a lot of the patients I've seen do seem to improve, even if they don't have other mast cell symptoms. So I always tell them I'm not sure if this is going to help, but starting you on high dose antihistamines like Zyrtec up to 3 or 4 times daily. There's other medications we typically use. So I have this discussion with the patients, just a regular mast cell patient that I see. And then, post-COVID, obviously, we kind of go through these things as well. So there are different types of mast cell disease, and I'll go into the last type as well. Another reason to check a baseline tryptase is if it's elevated. There's a new condition we found about 10 years ago, and about 5 years ago, we got an adequate test to evaluate it. It's called hereditary alpha tryptosemia, which basically means increased gene copies of tryptase. These people behave for all the world like mast cell activation syndrome, but they run in families. So if you have an elevated tryptase, we do a genetic test, and if that's positive, they can have this hereditary alpha tryptosemia. And we treat it kind of like mast cell disease. And again, it's not everyone, but some of the patients I've seen with long COVID have responded to similar medications. And like we talked about, that does make sense because mast cell mediators are elevated for up to a year after the acute infection in some of these patients. So mast cell disease is a whole other topic upon itself. And if you're ever on the fence, referring to someone who sees, mast cell disease, but it can be very tricky, especially when someone comes in saying they were diagnosed with this condition. So yes, I do think it is overdiagnosed.
And I'm so grateful for you to have walked us through this slide, because there is so much learning in this slide. And even as primary care physicians, I think we should be aware of this phenomena. The slide that you talked about, the symptoms of MCAS, I think there are so many patients who present to us with urticaria, and we just treat the urticaria, and we forget about the other symptoms like abdominal pain, like diarrhea. I think it's very important for us to be cognizant about those. So Drew, can you please walk us now through the treatment? How do we treat MCAS?
So, just to kind of go through, I had one other slide, the mast cell activation syndrome. Here's a slide with the criteria. Ideally, you want signs and symptoms of mast cell activation in 2 or more organ systems. So skin, obviously we see a lot of that, and we all see chronic urticaria, most likely do in clinic, but usually we like to have another organ system, GI, respiratory, cardiovascular, obviously. And again, tryptase is the most common marker, and even getting it a baseline is very helpful for us because that tells us, which of those categories it's most likely to be if it is due to a mast cell condition. There are other mediators. The most common are, I don't always get these because they're very non-specific, and I go more, off tryptase and a few other markers, but you can do 24-hour urine studies. That's something we can do if you have a strong suspicion. So there are other mast cell mediators, but again, the biggest one is tryptase. So as far as treatments, like I said, a lot of these treatments are something we use in our everyday clinics, all of us, things like cetirizine. Now, the difference with us and like with chronic hives or chronic urticaria, usually one Zyrtec is not going to work to help control that. I think most of you know what chronic urticaria is, but it's an autoimmune condition, chronic hives, more than 6 weeks. It's a very common condition, and I know most of you have seen it and managed it, but it's something we see on a daily basis in our clinic. And we know that usually one cetirizine is not going to cut it. But going up to 3 or 4 times the doses, and our classic dosing is either cetirizine or fexofenadine. The classic doses, cetirizine 10 milligrams, fexofenadine or Allegra 180 milligrams, but ramping up the dose. Typically, it's 2 in the morning and 2 at night. So 4 a day. And despite what the label says, that's very safe, and it's much, much, much more effective. So if you see chronic hives in your clinic, if there's no other warning signs, no other organ system, starting them on 2 Zyrtec in the morning and 2 at night. Usually we do that, and the hives are usually self-limited. So we usually do that for a few months and then try weaning off. We do have other medications like Xolair, which we'll talk about in a second. But a great first-line therapy, especially if they have skin symptoms, is just over-the-counter Zyrtec and Allegra, 2 in the morning and 2 at night. And I can't tell you how many people feel better, not just hives, but with their other symptoms, just on that simple therapy. I usually tell them to go to Costco, pick up the big bottles, and it's amazing how many people get better on that. So H1 blockers, but not at the normal doses, usually up to 4 times the dose. And actually, for chronic hives, to get other medications approved, insurance companies require you to be on 4 a day. So it's actually standard of care to go up to those doses. So again, with Zyrtec, Allegra, you're not going to run into a lot of problems with 2 in the morning, 2 at night. And that can improve a lot of the symptoms skin-wise, but I've noticed a lot of other symptoms improve as well. H2 blockers, I don't use these as much. As you know, they're low risk. Starting someone on Pepcid morning and night, especially if they have GI symptoms, there's really no downside there. So I'll often throw that if they have GI symptoms, just, simple Pepcid twice a day, and then the 2 Zyrtec or Allegra twice a day. That works really well for hives in most patients. And I've noticed a lot of the other symptoms improve with mast cell disease and even long COVID in some patients. Now, for GI symptoms, one we typically use is cromolyn. Cromolyn is a mast cell stabilizer that works mainly in the GI tract. But for people with severe GI symptoms, this is something I'll typically use. It's a liquid that you do up to 4 times a day, and it's not the easiest thing to do for patients. So I tell people this is written 4 times a day, but you do not need to do that. Most people do it morning and night or throw it in before the meal at noon. And I'll usually give people a month trial of this. Again, low risk. And a lot of the patients noted that their GI symptoms improved significantly. And again, there's not a lot of systemic absorption, but the cromolyn works well for GI symptoms if that's one of the major symptoms your patients are coming in with. As far as other medications we do use the leukotriene blockers, Montelukast, we've used a lot of. Now, we do use a lot less than we used to, and most of you know that it does have a warning, a black box, because of the neuropsychiatric side effects. It's rare, but I've seen a few people even with suicidal ideations on this medication. And so I do start it, but I tell people about this, and I tell everyone, look, if you have any of these side effects, just stop it. But leukotriene blockers, we do not go up on the doses of these, but leukotriene blockers are something we'll add in. One we add a lot of is ketotifen. Ketotifen is a mast cell stabilizer that works systemically and is an antihistamine. And we would use it a lot, but the issue is it's not available in the US in most pharmacies, not because it's not safe. We just didn't use it a lot until mast cell disease in our field became a thing about 15, 20 years ago. So when I first started prescribing this about 15 years ago, I could not find any compounding pharmacies to make this. Now, every compounding pharmacy in the Seattle area, compounding pharmacies in this area up in Bellingham will all compound ketotifen. So I will typically do 1 milligram 3 times daily, just send it off, or I give them a paper prescription, or if their compounding pharmacy will accept the electronic prescription, I write for 1 milligram 3 times a day. It can cause some sedation initially, but it's a great mast cell stabilizer that works systemically. So with mast cell disease, and I've had a few patients with long COVID that have seemed to have a nice response to this. Again, I don't have great data for this, and none of these, I don't have long studies that show you, but I do have anecdotal evidence, and we do have great data in mast cell patients that these are effective. So ketotifen is often a good option, and now it's much easier to get. And again, 1 milligram 3 times daily, you can get at most compounding pharmacies. Prostaglandins we usually don't treat. For some mast cell conditions, we'll ramp up aspirin doses up to 1,200 milligrams twice a day, things like that. But no, I usually don't do that. That usually only works for flushing. So I don't do aspirin or NSAIDs usually for either mast cell patients, and certainly I haven't used it in long COVID. But there's another medication we will use a lot for chronic urticaria or chronic hives, which is a biologic called Xolair, which is an anti-IgE monoclonal antibody. It initially came out about 25 years ago for asthma, and frankly, it's not a great asthma drug. We use it a lot now, but we almost always use it for chronic urticaria or chronic hives. It blocks IgE, which is not how chronic hives works, but it does have a stabilizing effect on mast cells. So it works really well for chronic hives. It works well for a lot of mast cell disease. And I've had a few patients with long COVID symptoms who note that this has seemed to improve symptoms. Again, this is all anecdotal, but Xolair is kind of one where we can get it approved if they have chronic hives, despite being on high dose antihistamines. So that's kind of one of the other ones. It's very safe. Obviously, the cost is way more than these other medications. These other medications are very cheap, which is another nice aspect. The Xolair is about $30,000 a year, but it is indicated for chronic hives. And certainly if these patients are having skin manifestations, that's one we'll typically use as well. So.
This was so comprehensive and so very useful, this slide. It's
I
just
actually made this slide
awesome.
when I was a fellow, and I've updated it obviously,
Yeah.
but yeah, a lot of these medications are the same. And actually, for clonal mast cell disorders, we do have other medications now beyond this, but it's amazing. We're still using the same medications, and for chronic hives, these work very well. And for most patients with MCAS, although it's variable, most patients seem to notice a significant improvement. And I can justify that, even if it's super tentorium. They're feeling better off 40 milligrams of Zyrtec, I'll take it. And I tell people, I don't know the underlying mechanism in long COVID, but because this works so well for these other conditions and there are some similarities, along with the low side effects, most people are willing to, give this a try for sure.
So Drew, you talked about higher doses of H1 blockers. So now the next question is spinning off of that. So some of our patients, they do not tolerate the H1 blockers. They develop either anxiety symptoms or GI abdominal symptoms. What do we do with those patients when we are unable to give them higher doses of Zyrtec or Claritin?
That is tough. That is a tough one. The Zyrtec, I actually really don't use Claritin a lot. It's usually the weakest of those. So I use a lot of Zyrtec. Usually I'll start with that. It's very potent and it's the cheapest at Costco, and some of these patients are on it long term. But I find that usually for people that have any side effects on Zyrtec, Allegra is usually my go-to after that. Again, 180, 2 in the morning, 2 at night, or just start with 1 in the morning, 1 at night, and work up as tolerated. If they don't tolerate Allegra, that's when things get more tricky. For chronic hives, that's actually an indication to get down here to Xolair. If you don't tolerate the high-dose antihistamines, then insurance companies will cover the Xolair because there's not a lot of other options there. So I admit, when people have side effects, I will say with mast cell, people having side effects on Allegra is pretty low, but that is a tough situation, Anita. It is tough to get around, and sometimes that's when we'll jump to these agents. Ketotifen I have tried for a few patients, but that is much harder to get. Cromolyn doesn't work systemically, and the H2 blockers don't work nearly as well as the first generation H1s, or second generation H1s. So it can be tricky, and that's a great question, and I struggle with that as well. But to answer, if they haven't tried Allegra, that's usually the least sedating, that usually has the least side effects. So Allegra I'll usually try, but after that it gets tricky, and yeah, let me know in that case. But that's oftentimes we'll talk about Xolair and these other agents, but that does make it a lot trickier.
So Andrew Simon has a very good question, and Andrew was our guest for our last session. Andrew is a naturopath. Andrew, do you want to unmute and ask this question, or would you like me to read it off?
Yeah, I can speak to it a little bit. So I just put 2 things in the chat. These are just 2 clinical tools I've used in my long COVID patients. Most of the data on the Interrogam is in chronic diarrhea, IBS, IBD, some of the CD4 cell reconstitution and improvements that you mentioned with someone maybe is already having an underlying, immunodeficiency. And there was a study that I was looking at that was like, as COVID enters into the GI system, it activates the ACE doorway, and then you start seeing all this like osmolarity happening because it's no longer absorbing certain key amino acids like tryptophan, leucine. There was a study at the end of 2020.
Some on that as well.
Yeah. And so I'm just curious, like when there's a dysbiosis thing happening, a lot of times I've seen some success after, rule outs of other chronic illness or IBD or after colonoscopy. I'll use these SBI Protect or other types of serum-derived immunoglobulins, which is what the Interrogam is as a medical food. Originally, it was researched as a medication, but because it's a medical food, we don't see a good pharmacy coverage on it. But it does help a lot in terms of my chronic diarrhea patients, my HIV patients in the past. So just thoughts around that in terms of a tool or strategy to bind, essentially, as the immunoglobulin binding to dysbiotic organisms in the GI system to lower that histamine issue and mast cell activation locally in the gut. And then my second question is around the diamino oxidase, with some individuals having shown deficiencies around that as a means to regulate histamine in the body as well. Thanks.
So yeah, so your first question. Sorry, what was that medication you mentioned?
It's called Interrogam.
Interrogam.
But technically it's a medical food, and it's really just it's a immunoglobulin derived from the serum of bovine.
Yeah. Yeah. It's actually funny. One of my mentors, Hans Ochs, who's an immunologist at Children's, he's one of the forefathers of immunology. He actually does use a lot of GI, actually IVIG, for some of his most severe patients. And his argument's kind of the same as yours. Not only may it neutralize, but it's also immunomodulatory as well. So do I have any data behind that? No, but it makes sense from a mechanistic standpoint. And probiotics, I never discourage anyone from doing, if we can, maintain homeostasis in the gut, or at least try to, overall the immune system, that's a good thing. It decreases not only, immune deficiency, but immune dysregulation. So I don't have, an IVIG or those products, internally obviously would be way too expensive to study or do that, about long term. But the idea there is great. And, I haven't heard of that product. I'll look into it. But, not only neutralizing things in the gut, but, the immunoglobulins that you give is immunomodulatory as well. And that was Dr. Ochs's theory behind that. So no, I don't have any experience with that, but the idea is a sound one. Now, as far as the diamine oxidase, that's something we've talked about for years. We don't use that test a lot. I don't discourage it in patients. It doesn't change a lot of the way that I manage this, but I don't discourage people doing diamine oxidase testing or DAO testing, but it's not something I do, and I don't supplement the antibody. I haven't seen studies on that. I certainly don't discourage it, and some of my patients take it, and that's great. But I don't have a lot of evidence for that. So no, it's a great thought, and I don't discourage that, but it's not something I typically test for. Great question.
Thank you. Yes, Drew, Andrew, did you have any other questions? No.
I'm pretty sure I do, but I'll think about it for a second and wait for other people to ask questions. Thanks.
All right, thank you. So Drew, the next question is, we often hear from patients that after they get the acute COVID infection, they have become more susceptible to acute infections, and they are getting cold after cold, and they have lower immunity. What is your take on that? And if this is an entity, what should they do?
No, it's like I mentioned in the beginning, when I first started seeing these patients, I thought, gosh, we're going to find an immune defect. So I did immune workups on all of these patients, and surprisingly, they turned out at least more normal than I would expect. When we do immune workups, we look at antibody levels, function, how well they respond to bacteria, viruses, and vaccinations, things like that. T cells, B cells, and usually you can pick up a significant immune deficiency pretty easily with those tests, and I just wasn't seeing a lot of that. So no, I've seen the same thing where people just seem to be more predisposed to more infections, but we haven't seen a lot of immune defects. Now, I think I brought this up earlier, that there's some thought that there's a low-grade infection that's that's causing your immune system to be revved up. And when your immune system's revved, you don't feel great, obviously. So whether there's some viruses hiding, whether there's reactivation of other viruses and the immune system not functioning properly, I've seen the same thing, but surprisingly, the immune workups, and I still do them a lot of the patients, especially if there's a history of other, frequent severe infections, I will still do immune workups, but I've seen the same things, but somewhat surprisingly, our immune tests, at least in my experience and what I've heard talking to my colleagues, have come back normal in most of these patients. So I will do immune workups, and that's part of why I was doing this. I thought some of these patients may have had kind of a lower grade underlying immunodeficiency. The COVID just kind of exposed this, and more predisposed to autoimmunity, things like that. But I've seen the same things, but I can't explain it based on the workup that we're doing. Again, we don't test mannose binding lectin and things like that in a general clinic. That's more like research based and things like that. But in the general immune workups, where that can pick up almost all of the clinically significant immune deficiencies in the normal setting, just haven't picked up. So I don't know. It's a great question, and I wish I had a better answer for you.
Thank you so much. This really helps. I think the viral persistence and reactivation of other viruses is a very important consideration. And I really, I'm grateful for your explanation on that.
Yeah, again, it's a weird phenomenon. We see that with DRESS. That's part of the diagnostic criteria is look for EBV and HHV6. And while it's part of the diagnostic criteria, you know, it's not something that we treat surprisingly. You know, a few of the severe DRESS cases and, you know, inpatient at UW, we would try antivirals and things like that. But it didn't really work, and there's not a lot of data to support it. But you wonder whether that's playing a bigger role than we think. But yeah, just like in DRESS, you know, we see that, but we don't know whether it's just indicative of another inflammatory process or whether it's involved in the disease process itself. So it's a great question.
Thank you. I think Andrew has another lovely question.
Yeah.
He would like to know your thoughts on the SARS-CoV-2 antigen or spike protein persistence as a driver for immune exhaustion. And he says he has seen people get better after they get vaccine boost. And in the long COVID clinic, we actually see it the other way as well. Sometimes their symptoms get worse. So what are your thoughts on that?
No, and I saw that, and that's a great idea as well. You know, I don't know is the answer. No, I guess I don't really have a good answer to that, just thinking off the top of my head. So yeah.
That's okay. So I think there's more research or more evidence to be reviewed on that.
No, like a lot of this, it is amazing that, it's relatively common. And like I said today, I saw this patient who had seen several providers saying, it isn't a real phenomenon. So obviously providers don't know about this. And, a lot of the patients just feel better knowing that you have some experience in all of this. So no, I talked to him about all the immune mechanisms, the potential, the causes, but that we don't know. And I think a lot of the patients just, 10 times and you just feel better knowing that you have an interest in this and are looking at potential etiologies. But again, the main area I focus are the immune system. If they have any other symptoms consistent with potential immune deficiency, immune dysregulation, autoimmunity, I'll do an immune screen. And most of these patients I do screen with, a tryptase for mast cell. And just because of the benefit, risk ratio, I will start most of them on high dose antihistamines. But I say, if you're not better in a few weeks, just stop it. And I usually will regroup with these patients about 3 to 4 weeks later, see how they're doing on these therapies. If they're not working, I stop them. But if they are, you try and get them on the, the optimal doses. And again, because these are so benign, even if I don't know the exact mechanism, I can sleep at night knowing I'm not doing any harm. And this does seem to be, improving it for these patients. So.
Drew, the next I want to touch upon this one topic where there have been several patients that you and I have shared, we co-manage, who have multiple drug allergies. They have developed this entity after they had COVID to where now any medications you try them on trigger allergies. Is this an entity that you have seen?
I think a lot of that, and maybe probably some of our patients as well, but I think a lot of this is chronic urticaria is getting triggered. And when people get antibiotics, that can trigger underlying chronic urticaria in patients, and just having other illnesses can trigger it as well. So a lot of times when people go on antibiotics with chronic urticaria, they will spike. But no, I have seen that as well, where people seem more reactive. And it's not just the chronic hives, they get other, symptoms as well. I do think a lot of that entity is people, because chronic hives is so common, 3 to 4% of the population experiences this. And, most people get COVID over the course of several years. So I do think a lot of this is just chronic urticaria being unmasked. And when people are getting antibiotics in the setting of illnesses, they're developing hives. So I think that's some of it, but it goes along with these other mechanisms. I do think there's something, immune modulating about this, that people are just more susceptible or more prone to develop adverse reactions. So the one thing I'm pretty sure is going on with post-COVID is that chronic urticaria is getting reactivated. So people are just more prone to react to things like antibiotics in general. But I agree that there seems to be more immune dysregulation, meaning reacting to things, either an allergy, which is reacting to some in the environment that's benign, or autoimmunity, reacting to something internally. So no, I agree. I think there is something more autoimmune, more allergenic associated with it, even beyond the chronic urticaria component of things.
This is such a good answer. Thank you so much. I have two other very good questions in the chat. Rancherjeet, do you want to unmute and ask your question?
Yes, sure. Hello, Dr. Ayars. Can you hear me?
Yes, yes.
Okay, thank you. So I have a question that can targeting mast cells help improve sleep disturbance in long COVID patients?
That's a great question. It's hit or miss. It's the same with mast cell. But no, I've had some patients that have improved, and this is one of the cases where we will often use something like Benadryl or even hydroxyzine at night. We use that side effect to our benefit if they're having some trouble sleeping. I don't do that long term, but if I think mast cells are playing a role, I'll say let's try some hydroxyzine or Benadryl at night to see if that helps. I will start them on the antihistamines. You can even do that in addition to high dose cetirizine or fexofenadine. But using some of the first generation H1 antihistamines, you can use at night to help with insomnia, but long term, I like to avoid that for a lot of reasons, obviously, but it is something I will try. But I have noticed, to answer your question, that even on Zyrtec or Allegra, in mast cell disease, if you target those with mast cell therapies, oftentimes things like insomnia, because of that brain fog and things like that, they also seem to improve. I don't have a mechanism behind it, but I have noticed that some people seem to improve. And again, these medications are very low risk because I would have a low threshold. I tell people, again, I don't know for sure this is going to help, but it's low risk and potentially high reward to start baseline either Zyrtec or Allegra at high doses, and then you can add in, something like hydroxyzine or Benadryl at night in addition. It's fine to take that even in addition to the high dose Zyrtec or Allegra. So yes, in mast cell patients, I have seen sleep patterns, improve on this. In long COVID, I don't have a lot of, experience with that, but certainly trying something like high dose cetirizine or Allegra, plus adding in a first generation with the, that crosses the blood-brain barrier like Benadryl or hydroxyzine may not be a bad idea. I tell them I'm not going to give this to you long-term to help sleep at night, but it may help in the acute setting, especially, when the symptoms are initially beginning. So, the second generation that don't cross the blood-brain barrier, Allegra, Zyrtec, and then adding in a first generation at night is something I'll often do.
Thank you so much, Dr. Ayers.
Thank you very much. And Nick put the short survey for you. It will be very helpful if you guys can fill it out. And before I ask the next question, I want to give an opportunity to Karen. Karen asked a very good question. Karen, do you want to unmute yourself?
Sure. Hi, thank you. I was just wondering, you had mentioned that the cognitive fatigue and the brain fog symptoms can also be part of the mast cell activation syndrome. So are you seeing that your patients on the higher doses of the H1 and H2 blockers is also helping with that symptom?
Great question. And kind of my spiel with patients is, these medications are almost certainly going to help with skin symptoms, a lot of the other symptoms associated with mast cell disease. And yes, I would say, a lot of my patients do seem to improve on mast cell therapies in regards to brain fog. And some of them, it's right away. Again, I don't know how much of that is supratentorial versus blocking the histamine. And I tend to believe them because they've tried a lot of other things before doing this. But yes, they do seem to improve in some patients. Now, I tell people initially, I can't promise this will improve the brain fog. Sometimes that's the most challenging thing to treat. Fatigue and brain fog are sometimes the most challenging. But I will say, at least in mast cell disease, majority of my patients at least describe, I haven't done placebo control or anything like that, obviously, but most patients do describe at least some improvement in their brain fog symptoms that they've been having. And yeah, the brain fog, that was one of the, the first time I heard it was when I started treating mast cell disease. And I thought that was more specific there, but it obviously is associated with a lot of conditions, and long COVID, it's one of the main manifestations. So at least for mast cell disease, I would say, a decent proportion of my patients do describe an improvement in brain fog and fatigue, although not everyone. So it's a great question. I would say the majority, at least in the mast cell setting, do seem to improve somewhat, but that's certainly not universal.
Okay, thank you.
Mhm.
I think Andrew has a question. Andrew, do you want to, Dr. Andrew Simon, do you want to go ahead?
Yeah, so it was just real brief, like the paradoxical reactions associated with an antihistamine. So like hydroxyzine, Benadryl, when they kind of go the other way that we expect, more anxiety, more insomnia. Just if you, as you, it sounds like you obviously use a lot of the antihistamines. So I'm just really curious from your perspective, what you do in those situations.
You know, usually with the second generation H1 antihistamines, you don't get that paradoxical reaction. And actually I get that same reaction. Actually, if I have too much Benadryl, I'm miserable. So I feel for those patients because it's not a pleasant experience when you do. But I will say with the second generation H1 antihistamines, that's exceedingly rare. So going up to, you know, for the Allegra, for the Zyrtec, I rarely see that. Now, like we talked about, you know, oftentimes they'll use the first generation at night to help people sleep. And I do tell, if you go up on the dose, that's a possible side effect. And there's no real way to get around that. I just get them on the lowest dose possible, because that is usually dose dependent. And I know that for myself. If I take one Benadryl, I'm fine. If I take two, I am miserable with that paradoxical reaction. But the good news is you really don't see it with the second generation H1 antihistamines. And frankly, I don't prescribe a lot of the first generation other than to help people sleep at night. So I really don't run into that a lot. And you probably, others probably run into that more. They may prescribe more of that, but I actually try to stay away. When I used to attend on the house staff service at UW, people would know I would come through because I would switch everyone off Benadryl and put them on Zyrtec or 2 or 3 a day. You know, so I don't use a lot of the first generation H1 antihistamine, so I don't run into that a lot. The Zyrtec and Allegra, usually you don't run into that too much. And, you know, I would, you know, obviously the H1 you need sometimes with that side effect to help you sleep and things like that. But I try and avoid those as much as possible. So usually I don't run into that a lot. But that reaction is usually dose dependent. So I usually, you know, start at a low dose and see how you do if you have a history of that type of reaction. So good question.
Thank you. So I think one last thing that Andrew put in, if you, how about SSRI reduction and then see hives as a result, especially
Yeah,
seen in have you seen that?
No, I haven't. I haven't prescribed that. No, you know, it's not. I've read a lot about it, and I've thought about prescribing it in some of the patients. And this group probably knows more about that than I do. The you know, serotonin reuptake and all that. And I haven't tried that, but it's something I've thought about doing in some of these patients, especially. But I'd probably refer them down there first. But no, I did read about that. I'm not an expert on that by any means, but no, that's something I would certainly consider.
Yes, and we do see lower tryptophan levels in these patients and SSRIs, especially in the setting of depression and brain fog. Actually, we do notice.
You use those a lot. Actually, one of my the practitioner, her husband is going through this right now, so she's very anxious to chat about this. But
yeah, we definitely have used it. And recently, I got an opportunity to go to the AHRQ grantee meeting, and we met with people from Emory. And actually, they are doing exactly what you said. They are giving people higher doses of H1, H2 blockers. And then they mentioned something very interesting, which is they added Strattera for brain fog, and they have noticed a difference along with SSRI.
That's interesting, yeah.
Isn't it interesting?
Yeah.
So they're giving this cocktail of medication, and they are noticing improvement in brain fog. And I know Andrew Simon will also be interested in, and this thing he probably is trying some of it already. So, you know, this combination is what they are prescribing, and I'm sure they have trials with Strattera as well. But
actually, you know, in preparation for this, it's not something I was typically using, you know, but no, I was reading some on that. It's, you know, so no, I that sounds like something I might use in the future. I might bug you about it, but no, you know, I'm not an expert, you know, in that aspect of it, but it's certainly something, you know, I would defer to the experts here, but no, certainly something I would try based on the findings there. So.
Thank you so much. And this was certainly for me. This is Immunology 101. This is Pathophysiology 101. This is Pharmacology 101. So I'm just so, you know, it's been such an eye-opening presentation today, Drew, and I'm so very grateful to you. Thank you very much for coming today, for giving us time, for making this interest group so very special with your talk. I
No,
really
thank
appreciate
you for
you.
inviting me.
Thank you
Yeah.
for this learning experience, and I'm sure all the attendees have enjoyed today's session. This will be recorded, and Nick will put this on the YouTube channel. And we will also, Drew, we will also share this with you. So
Yeah,
thank
and
you
you can
very
share my
much.
email with anyone. Feel free to email, you know.
Thank you very
So
much.
yeah, if any questions, please let me know. So no,
Thank you
thank you
very,
for
very
inviting
much.
me, Nita. This is awesome. So I really appreciate it.
Thank you. And we really appreciate you. Thank you very much.
No, good to see everyone.